this is a case presentation of jejunal diverticulosis, just to stress and focusing of surgical of rare this presentation. Is a female patient, 56 years, male, presented with to the clinic with a reduced appetite and epigastric pain, over distended abdomen, absolute constipation, repeated vomiting, and with history of cholecystectomy since 5 years ago. Physical examination, all lab investigation within normal, no abnormal any of lab investigations. A small incisional hernia at medial side of cholecystectomy incision, and also there is hyper-resonant abdomen and exaggerated intestinal sound. Maximum site of pain at the epigastrium and left hypochondrium. Plain X-ray was done. The early to the left side, which shows the localized distended lobe at the left hypochondrium, and another X-ray which done after about 8 hours later, it increasing with multiple fluid level in the same area, which is localized. Ultrasound, no free fluid, no abnormal pathology by ultrasound. So the differential diagnosis first was acute pancreatitis, which may leads to localized distension in the left hypochondrium, but the serum amylase was normal, also lipase was normal. Mesenteric vascular occlusion, no history of the patient with all coagulation profile was normal. The third possibility was intestinal adhesive intestinal obstruction, which is not logic because the patient about 5 days before with this disease. So we explore this patient without definitive diagnosis, just to exploration. The preoperative routine lab investigation, nasogastric tube, Foley's caster, and IV line for this patient. Intraoperative midline incision, formal abdominal exploration, we found diverticulosis of jejunal lobe, which is about 13 centimeters from jejunal flexure. The first time to see this diverticulosis. If you see this picture above this transverse colon, and also this divertically, which is inflamed, and all the divertically at the mesenteric border, which is false divertically, but no perforation, no air under diaphragm. So we resect. Only one is inflamed to the right side, which is inflamed. This one with pyogenic membranes. This is after resection of this basement with primary anastomosis. A smooth postoperative, the patient was fasting for 5 days with antibiotic and start removal of nasogastric tube after 2 or 3 days. Then the patient go home at the 7th day. Now, the jejunal diverticulosis may be presented with medical presentation, and we all today with a physician, okay, many accidentally discovered or asymptomatic, may be presented with vague abdominal pain, may be presented with anemia due to malabsorption or blind lobe syndrome. And the surgical presentation, it may be with obstruction, presented with obstruction, enterolith, or gastrointestinal bleeding, which could be happening from the ulcerative lesion at the diverticuli, or maybe due to perforation, which leads to peritonitis and air under diaphragm and surgical abdomen. But this patient with localized abdominal distension, no more. So, the question now, in case of patient who is diagnosed as diverticulosis, jejunal diverticulosis, conserve it or just to write in his record that the patient had a diverticulosis, or go to definitive treatment. And definitive treatment, it means surgical. It means resection of this basement. It means occlusion of it. It means inversion or simple excision. Thank you.
Thank you very much.
Okay, thanks.
Is there any question? I think this case was very clear. Do you think that the pancreatitis might have?
Pancreatitis, sometimes the pancreatitis slows central lobe, which is dilated lobe in the left hypochondrium. So we suspect when we do plain X-ray and so the film is distended lobe in the left hypochondrium, the first possibility is pancreatitis. Some sort of ileus, of localized ileus.
Congratulations, very nice case. Regarding your questions,
Yes.
your question, do you think that in the asymptomatic patient it is, or he will agree, the patient will agree with preventive surgery?
It's not a preventive surgery. It is for avoidance complication. If we explain to the patient that it may be suffer of complications, so and so and so, he may agree. When you open your patient on elective case, before then peritonitis, then perforation, then intestinal obstruction, the possibility of healing is good.
And what approach do you propose in this case, if it is asymptomatic?
According to the number of diverticuli, according to the site of diverticuli, according to the size of diverticuli. If it's one diverticuli, it may be with simple corrosion or invagination inside. If it's multiple increase in size, it's better to resect.
A resection.
Yes.
Okay, thank you.